Good evening. We didn't want to start tonight's chat without our coffee and tea, and hopefully everyone at home is enjoying your beverage of choice. I am so thrilled for you to be joining us this evening. I have been looking forward to this chat for a while because one of the most frequent questions that I get in the midlife practice is, I'm forgetting things. Is this normal? So tonight we're going to talk about memory changes and cognitive changes and how it affects midlife. I am Dr. Melanie Ochalski. I'm a reproductive endocrinologist and certified menopause practitioner, and I see patients at the Midlife Health and Wellness Center at WellSpan. And I am so fortunate to be joined this evening with Dr. Caplan, who is an internist who specializes in geriatric medicine and has expertise in dementia and Alzheimer's disease. Thank you so much for joining us.
Thank you for having me.
So, I forgot what I was going to say. Is a very common complaint of midlife. How many times have you walked to the refrigerator, opened the door, and then forgotten what you even went there for? What I want to reassure everyone listening at home is that changes to memory are not an uncommon part of aging and particularly the menopause transition. In fact, about 60% of women that are transitioning into menopause report cognitive changes, and in some ethnicities, the cognitive changes are more prevalent than hot flashes. So while we all are aware of some of the more common symptoms that we talk about, like the hot flashes and mood changes, cognitive changes can be pretty pronounced. However, when to worry that there's something more going on is the topic of tonight's discussion. So I have some questions that I prepared for Dr. Caplan, and then I hope participants at home will also send your questions so that we can answer whatever may be items that you are wondering about and wanting to get some advice about. So first question that I have is, what is the difference? When does typical memory lapses become more concerning, and when should we be worried that something more pronounced is going on?
So memory and cognition changes as we age, but that generally doesn't happen till around the age of 70. The incidence of dementia also increases as we get older. So by the time somebody is 85, there's probably 50% of the population will meet the clinical definition of having dementia. The differences between normal aging and dementia is really sort of glitch on functional changes. So people can be forgetful, but they figure out how to compensate and they get through the day and they can still take care of themselves and be independent. People with dementia are declining slowly over time. And as that decline progresses, at some point, they're no longer able to manage their daily life independently.
Okay. So it sounds like if it's kind of something that you're laughing about, but then you remember, I was in the refrigerator to get the butter, it's not disrupting your life, but when it becomes more problematic and...
Yes. So I think that people with Alzheimer's disease, we sort of discuss this at visits, and I oftentimes explain to people the difference between short-term and long-term memory. And I sort of say, like, even though short-term memory sounds like it's easier because it's sort of, remembering things that are going on now, it's actually something that you have to be able to do now. The other things you had already done and they're stored in your brain, but having to learn new things and to remember things now is what you're having a hard time doing. And that's why that's the problem. So kind of trying to, remember and learn new things and actually not being able to put it in at all is where the problems are.
You have prepared a few slides that I think might be helpful because in my world, I don't often think about the difference between dementia and other causes of memory changes. So
let's do the slide about the symptoms first. Like, what is the difference between, it's the last one. That
Yeah.
one. So the one, sort of the changes in cognition is what we call it. So when people come to the visit and they're talking about memory, I will spend time talking about other things as well, because memory alone is not enough to sort of to create a syndrome of dementia. It really is sort of more than that, because if it's just memory, you would be able to write things down, keep lists, it's really a lot more than that. And sort of this demonstrates all of the other areas that people will have issues with. And generally those issues involve the entire brain. So it may be issues with language, sort of coming up with the right words to express yourself, sort of, or being able to put your thoughts into words, being able to figure things out. So you may not remember things, but you've come up with a plan of how to figure things out, and that's why you can still be independent, so that you probably don't quite have, sort of, you would not meet the clinical definition of dementia. Changes in personality. So sometimes, on this slide, you can see withdrawal from activities versus mood and personality changes that would kind of be odd, where people maybe have paranoid delusions. They think that somebody, is, at their house at night. These would be unusual for somebody who is just, sort of feeling like, they can't remember things as well.
Yeah. And I hope that you folks at home can see can see what this slide is showing, because I commonly hear that I forgot where I parked my car, and certainly mood changes are common, can be common during the menopause transition, but it would not be a typical menopause sign to have difficulty speaking, or to be confused about time or place. So
right, and usually when, like, you couldn't remember, like, oh, I can't remember where I parked my car, you'd figure it out, right? Like, it's like, all right, I think I walked in through this door, and then you start looking. But a person with dementia may not be able to figure it out.
Yeah. And am I right that to some degree these can happen at any point in life and not necessarily be part of aging? I remember in medical school having a run of forgetting where I parked my car, and probably that was sleep deprivation and being consumed by other things.
I think and this maybe goes back to my first slide, where so when somebody's coming in for an evaluation, I'm oftentimes trying to make sure that we're not in one of these categories that we're talking about dementia, which tends to be a slowly progressive kind of cumulative process. Like, you start out with one symptom that was maybe something that you noticed like a few years back, but now it's 3 years later and you're having other symptoms, and it's progressive. And we oftentimes sort of say, like, it's slowly progressive global cognitive decline, sort of like you are starting to have other issues other than just memory. Whereas when you are maybe menopausal and you are stressed or maybe even depressed, there's other, it tends to be a more, kind of rapid process, and there are other changes that go along. Like, you can identify, like, well, I haven't been sleeping well, and other things are going on, and that's maybe why you're not functioning as well. And delirium is sort of this acute process where somebody just was fine maybe a week ago, and then now they're just totally off.
Can you talk a little bit about depression and how that could mimic or be confused with?
Yeah, so we talked about that a little bit before, but we have a diagnosis of something that we call pseudo dementia. So it's somebody who acts like they're having dementia and maybe sort of are functionally declining, maybe they're not bathing or changing their clothes and they're not showing up for work, but if you evaluate their condition, you can see that there were maybe mood changes that preceded this. They're telling you, they're endorsing the symptoms of depression. And, the difference between that and dementia is that depression is a reversible condition. And if you treat it appropriately, all of those symptoms will go away.
Okay. That's helpful to distinguish those different, the different symptoms and how those different diseases can present. I think a big worry for a lot of patients is Alzheimer's because it's not uncommon, and many women know someone who has suffered from it. And so the first thing they think about when they have some minor memory changes is, oh no, is this the beginning of something as concerning and progressive as Alzheimer's? You have a slide that I found helpful, but can you tell us a little bit about that?
Yeah, so a lot of people want to know what is the difference between the word dementia and Alzheimer's disease, because they hear sort of those two frequently and they're sort of used interchangeably. Dementia is kind of a group of conditions, and Alzheimer's disease is one of those conditions. So there are other conditions that can cause people to not be able to think clearly and to decline slowly over time, and to also have problems with memory and maybe changes in personality and visual, spatial kind of orientation skills, but not everything is Alzheimer's, although Alzheimer's is the most common condition that we see as part of degeneration of the brain, and 60 to 80% of dementia cases are due to Alzheimer's. And it is a condition that the prevalence of this increases as we age. But we're not talking about menopausal women. Generally, we're talking about people that are over the age of 80, 85. The life expectancy in this country now, like for men and women, somewhere around age of 81, I think, although COVID brought it down. But, so that's like the average, but there's a huge segment of our population that is, living into the late 80s, 90s. It's not unusual for me to have a patient that is 100, these days. So those are very different patients or different people from somebody who's menopausal.
So to reassure listeners at home, the percentage of 50-year-olds that are having memory changes, the vast majority are likely not.
Yeah, younger onset Alzheimer's disease. I don't know if anybody saw Still Alice with, that was with Julianne Moore. She won an Academy Award. That was maybe 5 or 6 years ago. But that woman had young onset Alzheimer's. It's a genetically linked Alzheimer's, and that can present in 50s or early 60s, but those are rare cases.
Okay, and we're going to talk shortly about what to do, if anything, different when there is a family history of some of these cognitive changes. If you're worried that there might be something concerning going on that's outside of the norm for typical aging, where should a patient go first?
I think, your family doctor is a great place to start. I think most doctors are well equipped to kind of start the evaluation process, especially as you get older and maybe are Medicare age, which I think a lot of the menopausal women are not quite there yet. But as part of Welcome to Medicare, physical and what is called the annual well visit, cognitive screening is part of that yearly visit.
Okay. So just keeping up with your annual visits, that would be that evaluation is built in as part of the default.
Yes.
And what So what does an evaluation look like? If you could.
So I think, it could be something, we can talk a lot about it, but briefly, it's when, it's just, as physicians, we know symptoms, and then we have sort of ways of trying to evaluate those symptoms. So part of the dementia evaluation should always include history, what has been going on. And I've given you some clues, when I'm thinking that somebody has dementia, their symptoms may have started a few years ago. It wouldn't be something that started last month.
Okay.
Unless, I'm thinking maybe they had a stroke or something else that was an acute change. So I start out with medical history. You look at the physical exam, somebody that looks completely normal, walks and talks normally, but is having cognitive symptoms, that is a person that's more likely to have Alzheimer's disease, because in that condition, the neurological exam is completely normal.
Okay.
Then we generally do a medication review. We know that older people, especially like all of us, as we are aging, more and more medicines get added onto your list. You go with this symptom, and and you couldn't, you had allergies and you Benadryl, but now you can't sleep, so you're still taking Benadryl, and so and medications have lots of side effects, and some of them are cognitive side effects. They can also make you, give you dry mouth, make you fall, all kinds of. So doing a good medication review and looking there is can be very fruitful. So, and there's a lab evaluation. We generally are trying to look for reversible conditions that can mimic confusion or slowness in thinking. So thyroid disease, we look for strokes, other conditions that can make somebody sort of not necessarily feel their best or be performing at their best. So that's part of the medical evaluation. And then we have like specific cognitive tests. And you might have heard of the mini mental status exam. There's something called the mini cog. And the mini cog is something that can be done within a few minutes. And basically you have somebody, you tell them 3 words, you have them repeat them, say, just try to remember them. I'm going to ask you to recall them. And then you have them do a clock drawing task. You basically say, here's a piece of paper. Can you draw a face of the clock, put the numbers in correct positions, and put, a time like 10 minutes after 11 or 10 minutes before, 12, something, that would, and then see how the person does that. And if they have issues recalling the words during the clock, they screen positive. So that's a positive screen. And then you have to do more of an evaluation. So that's the mini cog. The mini mental status exam is a little bit longer. And just as we were talking about, that you are trying to find out if there's symptoms in areas other than just memory. So in symptoms of like reasoning, in language, in ability to kind of figure things out, those tests try to mimic that. So on the mini mental status exam, you have recall questions, you have orientation questions, you have calculations like subtract 7 from 100, you have copying of a design, so they're trying to incorporate all of those areas that are brain processing. So those are the tests, and there's lots of other tests, but those are the ones that you might have seen most commonly.
Okay. So I think it's a great reminder that there are providers that are ready to help assess and hopefully reassure patients that that what they might be experiencing is typical aging, and if not, get you to the people who can help. So if everyone at home is thinking like I am, what can we do to prevent some of the natural decline in cognition that might be part of the aging process?
So we were talking about that. It's the body is like so wondrous, and there's so many intricacies in it, but it is like very redundant, right? Like we know that, like, we have the same receptors in lots of different places. They just do different things. So, but really the advice for the brain is not too different as the advice that we give for like bones and for muscles and for hearts. We want for people to, to eat healthy, to be well rested, to get good sleep, to exercise, and to be able to do that, you have to have good breathing and cardiovascular health. Mm-hmm. So if your brain, and by what we mean sort of to exercise the brain, it's of course kind of like the blood vessels, feeding oxygen, nutrients, but also to exercise it by learning information. So if you are a couch potato that just watches TV, or if you're the kind of person that is sort of doesn't socialize very much and doesn't do anything and doesn't really use their brain, some of the things that you used to know will be forgotten. So we've all seen that. Sometimes even in yourself, you haven't done. When your kids start school and you have to do those multiplication tables and subtraction, you get better at it.
Oh my gosh! Don't even talk about math.
So because we just haven't done it for a long time, but
so you have to exercise those areas.
Yes.
What about the apps or games that market themselves as being brain exercises? I'm trying to think of some of the common names, but is there any?
I think there's like Lumosity and
yes.
I don't think there's not one that I recommend, but I do like them. I think that when people are trying to find things to do, I think a lot of those web games do try and incorporate memory and attention and kind of quick thinking, sort of trying to figure things out quickly. So I don't think that I'm not sure if I would spend money to kind of join the club, and so you can play more and more games, because I think you can do that doing other things. So I think certainly what I tell my patients oftentimes is, people say they read. I said, well, okay, so why don't you and your husband should read the paper together, but then you need to talk about it. Tell your husband what you read. See if you can explain it, because people oftentimes read, but they're not necessarily processing it. I think in terms of exercise, dance is supposed to be a great cognitive exercise, because there's a lot of muscle memory. You have to learn new steps, mm-hmm. and it's also good physical exercise. So, and trying to learn something new is a good exercise for your brain.
I often tell patients, particularly when we get into libido, which is another common complaint in midlife, that libido can decline. And one of my recommendations is try something new together outside of the bedroom, and you can bring that, as you're developing new pathways and you're you're not in your rut, you bring that into other areas of your life. Are there any specific diets to avoid or special supplements to take?
So the diets that I would recommend would sort of be the diets that we recommend for cardiovascular health. So Mediterranean diet would be, a great, would be the right diet for most people. I think for some people that that maybe have a history of Alzheimer's disease and are trying to sort of go one step further, like the keto diets that really sort of limit processed carbohydrates would potentially be recommended, although there are no hard studies that actually show that. But the way it's apolipoprotein E4 that is the problem, and that's kind of the amyloid that's felt to be some of the processing that has to do with actually, and the carbohydrates stimulate those pathways more. So those would be, there are some centers that are kind of using some of these specialized diets. But generally just, eat well, Mediterranean diet, exercise, make sure your blood pressure is controlled. If you have risk factors for, strokes, heart attacks, you would want to minimize those. And there's lots of studies that show control of blood pressure reduces risk of dementia.
I love when it all comes back to a central recurring recommendation, which is be the healthiest that you can be. And what will make you healthy in one area, what will make your heart healthy, what I hear you saying is will likely make your brain healthy as well.
Yes, I think that, I think it sort of seems like a new discovery to all of us, but we're learning that that's, that this kind of like vital force in our life, this blood that kind of gets pumped around there's a reason for it. It does really make things, better or worse.
Yeah, I love it.
Yeah.
So when a patient is complaining of memory problems or difficulty recalling things that used to be on the tip of their tongue, one of the first things I ask them is, how are you sleeping? Because it's so common to midlife women to have poor sleep. And I think
Yes.
it begins for a variety of reasons, but then sort of compounds as we get older. Would you agree that sleep problems often can contribute?
Yes, there's a whole sort of study in dementia that is looking at lymphatic drainage in the brain, like what they are calling the lymphatic system and how you sleep, and that in terms of like clearing out sort of byproducts and toxic metabolites. But those, yeah, so
That's
I've gone,
very cool.
yes, I've gone to some, but we don't really know enough about that yet. But we do know that as we age, our sleep is not as good, and we tend to be more easily aroused. We don't sort of sleep as deeply.
Mhm.
So people oftentimes complain of sleep issues as part of, aging. And then we have conditions like sleep apnea, which can sort of outside of you not being well rested, it can increase your blood pressure and do all kinds of other things. So, and that, it's something that we can actually diagnose now and treat. So it's something that I look for when I'm seeing somebody who's having symptoms and maybe not quite, sort of not sure if they have dementia or maybe other things are contributing.
Yeah. And very common to my practice is the hot flashes and how impactful they can be on good quality sleep. And there is they did a study where they did show an association with the degree of hot flashes and the degree of cognitive change. And so I think, listeners at home, if hot flashes are part of what is being disruptive, know that there's treatments, and it's worth talking with your provider about. Okay, so we're learning to continue to eat healthy, get good sleep, practice ways of exercising our brain. Is there anything more or different that someone that has a family history of Alzheimer's should do?
It's kind of a hard question because I think that on the one hand, we want people to have an awareness so they can plan better. I think as of now, we don't have a cure for Alzheimer's and we don't necessarily have great treatments. So having somebody sort of worry about it and maybe get, sort of even early testing and to think that they maybe are at risk would certainly make them stress, but not necessarily create a plan where they can do a whole lot of things to prevent outside of what we're talking about. And certainly when there's genetically linked Alzheimer's, that's even harder to address through lifestyle changes, although we can probably modify things a little bit. But we want people to be aware and to try to plan for a future by maybe having their affairs, taken care of, so there's less stress. But generally, more so because of that we don't know a whole lot about sort of how to prevent the progression of the disease, or that we have, the testing for genetically linked Alzheimer's is also very imperfect. So we talked about this one called the apolipoprotein E, where if you have all 4 alleles, 2 from your mom and 2 from your dad, and the ApoE4, that gives you the highest risk of Alzheimer's, having all 4 copies be there, but it's not 100%.
Okay, so even if you have all 4 copies,
even if you have all 4, it's not 100% because there may be other modifying risk factors that we haven't been measuring yet. So generally, we're not recommending it because we don't know what we can tell you, what you can do differently outside of being aware that you have a strong family history and it may be something that can happen, maybe in the next, 5 to 10 years when we can actually maybe have drugs that can reverse changes, because our best bet at not getting to kind of the stage of dementia is to catch people early to prevent the decline. That sort of will be important. But I think at this point, doing a lot of genetic testing in people that maybe whose mom had Alzheimer's is not going to necessarily lead to a better life.
Okay.
Probably a lot more stress and worry.
And maybe unnecessarily so.
Yes.
Okay. That's very helpful. Well, I think we can go to questions.
Very recently, I noticed Mayim Bialik, who I adore. I think she's awesome. She's the actress who was on Big Bang Theory and is one of the hosts of Jeopardy now, and is a neuroscientist. She is now advertising a supplement to help ward off dementia. And it makes me a little uneasy because I don't want people, we've talked about supplements before and about how it can be very misleading and get people's hopes up, and they are spending a lot of money and perhaps taking supplements that really they shouldn't be taking for other reasons. So could you address that?
So yeah, there are quite a few supplements over the counter, and none of them have really sort of demonstrated greater benefit over, what we talked about, just kind of exercising and eating well. Turmeric is thought to be helpful because it's in that apolipoprotein pathway of kind of metabolism, but I don't think that there's really great evidence of what kind of turmeric and how much. And I think we all know that sort of like eating something is not the same thing as actually getting it into your blood. Right. So I think that people, for something like turmeric, lots of people take it, but we don't necessarily have great guidance about how much. And I am like you. I always tell people, I first ask like, well, how much does this cost? And I think that you might be better off going like maybe joining the JCC and doing a class, right, rather than spending money on this.
Right, the tried and true would be just sticking to a healthy, well-balanced diet.
Everyone's always looking for a pill to fix things, and I can't blame them. Okay, we do have a question from one of our guests. I'll just read it. Thank you for talking about dementia, depression, and delirium, but can you discuss the cause of what is creating the brain fog during perimenopause? Is it fluctuating hormones?
That's a great question. So brain fog, as I mentioned, is so common. More than half of patients will experience some form of it as they're transitioning into menopause. And for most women, it's probably multifactorial. So a combination of sleep not being great, perhaps other factors that are happening externally, like career changes, family changes, perhaps kids are going to college and dynamics are creating new situations that can add a little bit of stress. And then there is an impact from the hormonal changes that occur. And what seems to be the case is that they do preferentially affect the frontal lobe, so can impact memory, ability to multitask. And so what would be expected is that these symptoms may occur, but they shouldn't be disruptive. So they shouldn't be, happening at a frequency or severity that you can't hold down your job or you're putting yourself at harm. And also, it seems to be pretty limited to that frontal lobe. So it's not, you're still able to draw a picture of a clock, or it's not affecting your ability to balance your checkbook or anything like that.
you should still be able to kind of get through the day and sort of be able to function independently.
Yeah, it can, but I want to relate or tell folks at home that it can be really disconcerting. You feel like you're in like a brain fog. And the first thing is to check your foundation of health. Are you sleeping well? Are you eating well? Are you getting good exercise? And if you're not, what's impeding that? So if you're not sleeping, is it because your partner is snoring really loud, or is it because you're waking up drenched in sweat? And then there are, whatever fixing those factors looks like, is definitely worth it. So this isn't something that we want you to just tough it out, but I'm a big believer in addressing what might be wrong and trying to fix it. The typical progression through menopause is that those cognitive changes do rebound. And we don't know a lot about it, but the brain seems to adjust to this new hormonal milieu. If a patient's having hot flashes and there's a reason why hormones may be indicated, there also can be an improvement with hormonal therapy. And so I want to be clear, I would never put someone on hormones for the sole purpose of trying to fix their brain fog. But often when there's associated hot flashes and there's other issues going on that are improved with hormone therapy, it's not surprising that there's an improvement also in those cognitive changes.
What a perfect segue into the second question. I'm sorry, Dr. Ochalski. You just answered it. Do you have any suggestions on preemptive measures to take to get better sleep when having menopause, hot flashes, etc.? So do you want to expand on that a little bit more?
Yeah, why don't I'll talk a little bit about the hot flash piece, and then I'll see if Dr. Caplan has anything else to add. So for hot flashes, anything that will keep you on the cool side is going to prevent how often you get hot flashes and how severe they are. So go to bed, feeling a little chilly, dress as minimally as possible. Don't have heavy covers on. Patients have found success pointing a fan at their feet. There's commercial products that like the chili pad, you can place under your sheet and set the temperature. So all of those things can improve, can prevent hot flashes from happening. And then there are some good sleep hygiene tips that I like to review with patients. But I feel like
I think they're probably the same ones as I review with people, just, don't nap during the day, no alcohol before you go to sleep, no beverages with caffeine, exercise, those would be.
And what I've found, for a lot of patients, they may not have been as sensitive to, for example, alcohol. But then as we get older, there's more of that rebound. I'm up at 2 a.m. and now I can't fall asleep. So
right.
Being aware of some of those changes can be really helpful.
Yeah, I think those are, just trying to, because that is a very, very common complaint. And the one thing that I, for my patients who are older, for whom some of those issues are in a way a chronic condition, I try to teach them how to manage their condition, that it's not necessarily going to go away completely, but we can make things better. And you're going to have some nights when you're not going to sleep well. That's okay. We can't expect perfect sleep, but it doesn't require, taking all of these medicines or something. So, but, there's lots of great like meditation tapes, having a quiet space, white noise, just also not napping and exercise, I think are probably the best things for people to do.
I love my sleep. I can't sleep without my sleep mask. I need complete blackout, because even that darn phone charger, like those little lights can, for some people, be really disruptive.
Well, once again, you have pre-answered the next question. Is there anything non-habit forming to help with sleep when you cannot do hormone replacement therapy?
So before I answer that, I had forgotten one other thing I wanted to mention. A big depriver of good sleep is waking up to go to the bathroom. And there's a few different reasons why that happens, particular to midlife women. But for a lot of us, we just kind of got into this habit for a variety of reasons, maybe during pregnancy or postpartum, or we had a bladder infection. We started waking up in the middle of the night to go to the bathroom. And humans are so good at forming habits. And so what often happens as sleep gets disturbed is we think, oh, it's 1 o'clock, I'm up, might as well go to the bathroom now so I don't have to get up later. And what I tell patients is if getting up to go to the bathroom is part of your routine, try to avoid anything that's going to fill up your bladder and those bladder irritants like alcohol and caffeine. And unless you really have to go, try to avoid getting up, because that I found that to be a big culprit of poor sleep or driver of that. In terms of supplements or things that can be that we can do to help improve sleep.
So I prescribe melatonin. Well, I don't necessarily prescribe it, it's over the counter, but I do counsel people to try it because it is fairly benign, and it does seem, there are studies that have shown that it can be helpful. I think the doses, how high of a dose to take, can be variable for people, but it still seems safe enough to take even some of the higher doses that are over the counter, like 10 milligrams. So I generally have them try that. There is sort of a prescription form of more kind of purified melatonin, but it's quite expensive. So I generally just have them take that
over the counter supplement. And it seems that there's more data that perhaps there's other, besides sleep, melatonin can positively impact other areas of health. So not an expert in that, but maybe there's a 2-for-1 there.
It's worth a try. And I don't think that there's great data that says that it is it'll work for everybody, but it does seem to work for a lot of people. Some of it is probably the placebo effect, but it's benign, and generally for most people it doesn't have any negative side effects. So they try it.
When someone has tried melatonin and it hasn't been helpful, I often will suggest magnesium. Do you have an opinion about magnesium as a sleep aid?
I generally don't use it, but I think certainly because my patients tend to have, renal issues and other cardiac issues. Right. So I generally don't use magnesium, but I think, over the counter strength will probably, and I do recall that, it can probably be somewhat helpful. So yeah, why not? Yeah. I think for a lot of people, it's what you said, it's habits, it's bad habits, and sort of like, some people just get stressed right before they go to sleep because they're worried about not sleeping.
Right. It becomes a little bit of a vicious cycle.
Yeah. So I think giving them, maybe trying to address that piece of stress to try to get them to sleep, that would be something that I would consider.
Yeah. But other than that, so melatonin and magnesium are the supplements that come to mind. But
yeah, I think we were talking like I would sort of put it in the realm of like sometimes it's anxiety, depression, so kind of addressing that piece of it, and a lot of the antidepressants do help people sleep. So
yeah.
I have a guest who says thank you for bringing up magnesium. I understand there are many different kinds. Which would be utilized for sleep?
I think there's more than a dozen different types of magnesium. So magnesium is always bound to another element, and most of the magnesium formulations can have a relaxing effect, and they, depending on the formulation, may have a side effect that may be more or less favorable to the patient. For example, when you go to the store, magnesium sulfate is a pretty common, or magnesium citrate are common formulations. And one of their side effects can be increase in stools. So if you suffer from constipation, that's a good side effect. But if that's not what's an issue for you, that might be negative. You may have too frequent of stools. Magnesium threonate is often marketed as a brain healthy supplement, but unfortunately, from my knowledge, a lot of the supplements, there's just not great data on it, and the data that's there may have used a different formulation than what another study has used. So supplements are limited by a lack of good quality data, but to answer your question, there's so many different formulations, and I think the most commonly found one that you would find locally is the magnesium citrate.
Yeah, no, I agree with you. I think it's hard to, I think, as you know, you probably, if you can find, if somebody can eat foods that are high in magnesium, you know,
like dark chocolate.
Although it has caffeine.
It does.
And I know bananas, actually, when part of their processing is the melatonin pathway. So sometimes bananas can make you sleepy, but a lot of times bananas also have a lot of carbs. So you have to be careful. So
always something to think about.
Yeah. Okay, well, I have to go back to something else that you've been discussing, is depression, and the fact that that very much can affect your memory, the brain fog. So I just wanted to reassure some of our guests out there that I personally have dealt with depression since my preteen years, and I'm way beyond menopause, unfortunately. But with COVID, it reared its ugly head pretty severely a couple of times, and my memory was gone. It was frightening, which of course did not help the depression. Right. So, but it's well under control. I have a wonderful primary care. Anyway, I just want to reassure you that treat your depression and you may be shocked at how your memory comes back. So that was just my little 2 cents in there.
Thank you for sharing that. I think
Sure.
Probably more patients suffer from some of these symptoms than most are aware. And I think knowing that it's a pretty common, mood changes are common as we get older, and particularly for midlife women, it can be something that is problematic, and there's so many great resources, and you know, we're so fortunate at WellSpan to have experts in so many different things. So I would probably start with seeing your PCP, and then as needed, we have amazing doctors like Dr. Caplan who can help.
Yeah, I think we were talking about it, and I said that you asked me like who would somebody be referred to if they're having those complaints, and we talked about, you know, starting out with a primary care doctor who can do some basic testing, but then if it's an older person, you know, geriatrics, we have neurology, and we also have neuropsychology who you know, can sort of do a battery of cognitive tests if we're not really sure what's going on.
Yeah.
So that we do have all that here. May not be an appointment in a week, but in 6 months.
For depression, are there methods that don't involve antidepressants?
So that's a great question, and I would absolutely say yes. And I think, you know, you probably from your own experience would know that, but we know that for most conditions, medications alone are not enough, right? Like if you know, you oftentimes need to do something else. So you have medication plus therapy, because part of depression is being able to recognize your symptoms and then sort of learn how to cope and sort of do some of the, you know, kind of cognitive behavioral therapy that would go along with it. So I would say that for most people, medications are not enough, that they should be engaging in some sort of therapy, at least to develop some insight into their triggers, into their symptoms, so they can cope better.
Yeah.
And if I can make a comment on that one too, what has worked for me has actually been life-changing is regular exercise. And I mean regular exercise. It truly did completely change my life like 15 years ago. And with COVID, it stopped, which is why my depression came back. But I'm exercising again and it's gone. So there are so many, as you just said, there are so many different things that you can do in changing your lifestyle. And medication certainly does help, but you can't just depend on that.
Yeah. I appreciate again that you shared that experience. So often when patients come to us, they're understandably very distressed, and it can be frustrating to hear, well, exercise and eat better, but there's really no magic pill that's going to fix everything. But changing some of the lifestyle factors that over the years may have built up can really be that magic pill that can start to chisel away at a lot of some of the disease processes that may be contributing to whatever symptoms are bothering you. So I think that's great. And coming up in March, we are going to have a wonderful guest lecturer, Dr. Kelsey Steele, who's a behavioral therapist. And if she were here, she would say, yes, there's a lot of different treatments for depression besides medication. Let me tell you about them. So I hope that you guys will join us in March with Dr. Steele, because she has a lot to share about depression. And while I'm making plugs for future chats, we talked about the importance of heart health in our brain function, and that's the topic of next month's menopause chat.